joining us for this week for MDA's educational webinar on OPMD. My name is Jessica Hubbard. I am the Manager of Community Education at MDA. We are thrilled to have you join us today on Rare Disease Day for this webinar. This learning series is part of our larger MDA community education programs, which focuses on bringing the neuromuscular disease community together around education and resources. Be sure to visit the community education section on mda.org for updates and on upcoming events. We are recording today's event and will be posting it to the website for on-demand viewing at a later date. Please know that all phone lines have been muted, and we will have a question and answer session at the end of the webinar. You can use the chat feature to type in your questions and feel free to send them in as you think of them. They'll be addressed after the presentation. For over 70 years, MDA has led the way in accelerating research, advancing care, and advocating for the support of our families. MDA's mission is to empower people living with neuromuscular diseases, such as muscular dystrophy, ALS, and related neuromuscular diseases to live longer and more independent lives. Our mission comes to life through these 4 pillars. First, care. Through our national network of MDA care centers across the U.S., we support individuals and families from day one of their journey. Second, champion. Through our advocacy and education efforts, we empower families with information and resources. Third, catalyst. Through our investments in research, we are furthering advancements in treatment discoveries. And fourth, community. Through our programs like Summer Camp, our Connections program, and our community events, we are helping individuals and families build supportive connections and relationships. If you haven't done so already, we invite you to join the MDA community by registering with us. The objectives for today's webinar are to learn about OPMD, learn about current research surrounding OPMD, and learn about available treatments and treatments in the pipeline for OPMD. We would like to thank the OPMD Association for partnering with MDA for this webinar. I would now like to introduce our presenter, Dr. Bernard Brace, Director of the Rare Neurological Disease Group at McGill University. Welcome, Dr. Brace. Thank you for being here. I will now turn the stage over to you.
I hope what I'm going to talk today will bring forward questions, but also give you some answers. So the outline is I'll give you a brief review so that we're all on the same page of how we came to know OPMD as we know it now. Talk a little bit about onset, because it's often important in the families who start worried, do I have it or not, a family individual. I'll talk a little bit more about that. I'll talk about also about the other end of all of our lives, but in this case, aging with OPMD, which is important. Then I'll talk really minimally about understanding the pathophysiology. I know one of the theme is research, but research is a now thing. And I think at this point, I'm mostly addressing patients and families, so I will say minimally. I will talk about the treatment or the treatments. And I will also talk a few words about the research at the end. So a brief review of OPMD. So this is the first published picture of a clear OPMD patient. There were other cases in literature published by Taylor from a Massachusetts family, which was French-Canadian, in fact, living in the northeast of the States. So the first family of OPMD, large family, was a French-Canadian family. It was named, however, the disease was named in 1962 by Victor and Adams, working at the Mass General, and they defined very well the disease, including the lower extremity weakness, but really insisted on the cardinal ocular and dysphagia. And interestingly for us, French-Canadian was not really based on French-Canadian families, but really on an Ashkenazi Jewish family. They stated again that it was usually a dominant. What it means is that an affected parent has every child of that parent has a chance in 2 of getting it, though we now know that there are also very rare recessive forms. The dysphagia in these cases, as we will see, we'll discuss more, is usually late 40s, early 50s, and the ptosis, the eyelid drooping, is the same. The proximal leg weakness, as I said, was mentioned. We're going to come back to all of that many times during the talk today. And there's a lot of variability in families. That's a very important point. It's not because your mom or your dad had a severe form of the disease that you will necessarily evolve like them. So there's always a risk of a mirror effect, particularly in this disease where people start their symptoms usually at the time as the affected parent is starting to run into major problems or challenges. So then there is always often a mirror where the people say, oh God, I'm going to be like that in 25 years. This is not possible. It can be quite different. And hopefully drugs and other treatments will make the people who are starting the disease now, who are not manifested now, have a very different evolution. In 1980, my two mentors, Fernando Tomé and Fardeau, really describe a pathological marker, which is what you see at the end. And that's maybe a link to when we're going to talk about the pathophysiology. So it's one of the disease that had good definition, good mode of transmission, and a pathological marker. And until we found the genetics, people were recognized and made and were diagnosed properly by pathology and combining clinical and pathology. It's a universal disease. We know now it's all over the world. It has no boundaries. There's not many cases found in Africa, but besides that, there have been cases everywhere. The exact prevalence, that means how many cases per 100,000 or more, is only known in a few places like Northern UK, 1 in 100,000, where the data is pretty strong. France, 1 in 100,000 also. Southern Western USA, it's an estimate. We talk about Arizona, New Mexico, California, 1 in 15,000 maybe. And I say maybe. In Quebec, it's estimated 1 in 1,000 because of the founder effect. And Bukhara Jews living in Israel, there's only 30,000 more or less of them. It's 1 in 600, so it's the highest prevalence. But really, it's all over the world, in Japan, China, everywhere. So that's the paper that some of you may have learned or talked about. That's the time where we described the first description of the mutation and the gene that was involved, and it was great because it was easy to test, and essentially it's a region of the gene that codes for 10 alanines, and what you see in patients is usually between 12 and 18 alanines, though some people only have 11 and won't develop a disease in my book, so that's still controversial. And what you see on the right, and I hope you see my arrow, is what we see as the beads there is when we look at the sequence of these individuals, we realize that there's a lot of way of coding these increased size. So in fact, what it shows very clearly is that the mutation has appeared over history many times in many populations. That's what we know. There's also some distinct point mutations, which I'll say a few words in a minute. So we developed diagnostic criteria a long time ago in 1995, essentially for what we call linkage analysis, to be able to follow a disease in families when we didn't have a marker, or we didn't want to do a biopsy on a 50-year-old to know, do you have it or you don't have it. So clinically, people had to have a late onset ptosis, had to have a dominant mode of or dysphagia, a dominant mode, and then we develop objective things, which is confirmed ptosis, and measuring the size of the eye in the mid pupil had to be less than 8 millimeters. We had a swallowing test that allowed us to see, do you swallow really slowly? And if you had all of that, you had OPMD clinically, and it was pretty robust. But as you will see, it's not perfect because it evolves with time. 1998 changed the world. We had a pathological marker before, then we have a biological genetic test that's absolute, and then that allows us, and that's the criteria now. You have clinical OPMD if you have symptoms, but you have confirmed genetic OPMD if you have the test, even if you don't have symptoms. So let's talk about the first symptoms, because often people don't go through 10 years of wondering, do I have it, do I have not have it? So we did a lot of analysis of that in our families when we went back, looked at who had it and who had it not got it, depending on symptoms. So example, coughing, having some choking is not really specific, but some people will complain of more choking, but it's really not a very good predictor. What's a good predictor if you have it is you're taking more time to eat. So if you're at mealtime and you're with your buddies and it's taking more time to eat, that's probably that's pretty good predictor in the 40s that you have it. Or if you start avoiding certain food, or you really realize that peanuts and dry stuff doesn't go down as it used to, that's probably an early sign. And the droopy eyelids, it's difficult. We're all asymmetrical and so forth, but that can be hard to spot initially. So it's very hard to know when it appears, but you have to remember that it will always be asymmetrical. It's never the two shut down at the same time. It will be one before the other. And then there's never weakness at the beginning. So if there is weakness in a family like that in your 40s, you have to think of something else. You have to consult because it's really something else. So this is a complex image. I like to use it, but I think if you follow me, the idea is the same. This is people with two sides of mutation. The blue is from Uruguay with a bigger mutation. The red is from Quebec. And this is essentially the percentage, so 50%. And this is using the criteria I just mentioned to you. Really, it's around the age of 55 that in Quebec, 50% of the people meet the criteria. That means either their ptosis or their dysphagia is not able to be objective. It's maybe higher rate in if you have a higher mutation, therefore meaning that it starts earlier. But really, the average age in a recent study from Science is 54. We used to say more like 48, 50. So it's variable. And in the same families, it can start, there can be up to 10 years difference between the onset with the same mutation. Same phenomena with the dysphagia. It takes, before 55, only 50% of the patients will complain of true dysphagia, or at least meet our criteria, and depending on the mutation, obviously. And the limb weakness, you have to remember, and I'll show you some data later, it's about 10 years later. But you can have limb weakness, proximal limb weakness starting in the legs, even in the early 50s. And we even have, unfortunately, very severe case who will have it earlier than that. And I'll come back to it so that we don't confuse things. It's usually still something in their 60s. So the question for you who are listening today, not all of you have the 13, which is the one that we find in French Canadian, that we find in people of Latino origin in southwestern United States. It's also the one that we find in Ashkenazi Jews. So it's the common one. 45% of the population in the world have this one. But there are other mutations, and this is a classical French study that says if you have, and it just shows essentially the age of onset, which is here, and the different mutation. And the bigger the mutation, then it should start earlier. It's probably true, but what you need to remember is what you see here, which all individual case showing that it's very broad. So even with our 13, the one in French Canada, some have an onset in their 30s, but some will have an onset, according to this, in their 80s. Same mutation. So there is a lot of variability. So yes, overall, the smaller, the later you're going to start, the bigger, the earlier you're going to start, and the more severe. But it's not a perfect. So it's not what I call a very clear crystal ball as to how it will evolve. But still, it's a trend. But what we've learned early on is that some people have it very severe, and those people. These are images, published images from Bukhara Jews from Israel. And then you see the poor patient at the age of 38 already affected, like some people in your families in their 50s or 60s, and age 56, extremely a lot of muscle weakness. I mean, he can't hold his jaw anymore. Those are people who unfortunately get two dominant mutations, 213, and they're really sick. We have cases in Quebec, they die earlier, they have all types of more diffuse muscular dystrophy. Most people don't have that, so please don't be worried. It just shows that one copy of the gene is not good, two copies is really not good. In fact, some people in the population have a large size, what we call a dominant mutation, and a small recessive mutation. And if you have two of those, they will start earlier. So that's why we ask people to be tested, particularly the ones who have an early onset, to know if in fact they're unlucky and they've received two doses of an error, two errors. One from the mom, one from the dad, and therefore they will evolve differently. So it's something one of the reasons why it's good to be tested. Even in a family where we know the mutation, the common mutation, let's say is a 13, we will still test them to be sure that there's another one that would influence severity. So aging with OPMD. So I went from the beginning, a little bit, some of the symptoms that add, but what does it mean to age with this disease? This is not a quality of life disease. It really has a big impact on quality of life. But the question, will people live as long? There's no strong evidence that people die earlier with this disease. Doesn't mean that the last years are not very difficult or difficult. Again, the experience can be variable. So in fact, the study in Saguenay, where they looked at 300 patients and over 100 had passed away, they came to the conclusion, though it's not really in the paper, but I was involved, overall, it's the same life expectancy than common people. So it's not a reason for insurance, for example, to discriminate for life insurance. But from the beginning of the eyelid ptosis, men will die within 21 years on average. So it can be 40 years, but there's still a lot of life and a lot of good quality of life after. Same thing for the dysphagia. What we see, however, is when you have limb weakness, then because it's more late, I said about 10 years, naturally, the time from when that appears and the time you pass is shorter. But it's still the positive message is that life expectancy is close to normal. What however happens with time is all the issue of mobility. The weakness starts in the lower extremities. The muscles that are affected are the muscles that are important to go upstairs, to walk up hills, to raise from your chair. And with time, some people will develop also arm proximal weakness to a variable degree. But the message here from this very good also study from Bisson et al. From Saguenay, a more recent one, is look at this. That's that's the carriers of the 13 size mutation between 65 and 65 and 69. Not a quarter of the people need walking aids. So they're still doing pretty all right mobility wise. In fact, it's only in the early 70s that you start passing the 20, 30, 25% and using simple walking aids. And later then it becomes greater. But if you look at wheelchair, which is often a concern of everyone with a muscular dystrophy, doc, will I have a wheelchair later? And they may remember that their grandparent or their grand-aunt or their parent went to a wheelchair, but overall it's still less than 25% in the above 80 group. Again, this is homogeneous for one size of mutation. There are often adaptations that are needed at home. They can be minimum, they can be more important depending, but you don't want to hear that it's going to go that way, but it's still many people. And I always give the example, I had an 82-year-old who was still golfing at the age of 82. So it's still possible. So if one needs to stay hopeful, but the earlier you start having weakness in your legs, the impact on your mobility will be more important. It's not perfect and it can be multifactorial as we age. And I know we have joint problems and other issues that can affect our mobility, but still, compared to a lot of the other muscular dystrophy under the umbrella of MDA, it's pretty good in terms of mobility, but it's a declining quality. And then the question of death, I don't want to skirt it because it's an issue. Do we die of this disease? A lot of people come to me and, will I die of this, doctor? Most people don't die of this. It is true, and that study showed it very well. A lot of people will have, at the end of their life, people will declare that they've died of a respiratory condition. So people die of respiratory condition, pneumonia and so forth, probably 5 times as more of other people. But the causes of death are usually the same as in people not affected with cardiac disease and cancer as being the top and not OPMD. So life expectancy is pretty good. Death may be respiratory, but again, if people have respiratory symptoms and they're treated early, they will have a longer life. So it is true, but it still doesn't explain most passing. So I'm going very quickly. So the understanding the pathophysiology. So I wanted to say, look, we found the gene in 98. So we're 25 years later. Between you and I, we still don't know, okay? We know a lot of things. We've learned a lot of things, and many of the technologies have been used to try to understand what's going on. it's clearly a premature aging. We clearly accumulate the filaments, you remember from the Tomei thing. The filaments include the abnormal protein that aggregates and tons of other stuff. It does these, it explains very well the inclusions that were so the classical pathological hallmark in 1980. So there is a clear relationship between the gene accumulation of the protein. The question is, does the accumulation of the protein cause the disease? Is it the response of the cell trying to cluster this abnormal protein? Is it because the abnormal protein interferes with the normal function of the protein or decreases the amount? We don't know. Is it so there's still a lot of interesting questions and important ones. I think at this point, if we think of this as a premature aging, there is very good data suggesting that if you look at the muscle of aging patients, some of the change that muscle go through as people are aging are maybe accelerated in OPMD muscle. But the final answer is not completely out, though there is really great quality work on that, but there's still some understanding to be derived. So it's the idea, and if you read the literature and you'll see all types of chapters on that, it's all, do we think it's the inclusion that caused the disease and in a way create a new problem? Or is it because the inclusion is a reflection of the fact that you have less of the good protein and therefore that leads to the dysfunction? And the reason why it starts late is it because we exhaust our muscle with time? As you know, muscle has a great capacity. It's my favorite tissue. It rejuvenates. But we know that with time, the capacity to rejuvenate diminishes with age, but also diminishes if our muscle have to go through a lot more regeneration because there's an underlying disease. So it's a combination of factors, and thinking of therapies, we need to understand all of those. But because it's a genetic disease, more we focus on the abnormal gene and abnormal protein, probably the rational treatment will come from that rather than other things. But many things have been discussed, and we will mention them at the end when we talk a bit more about what treatment are on the way or have been tried. So I wanted to spend a lot of time on medical treatment and physical treatment. My impression is that in Quebec, because it's so common, most of neurologists who work in neuromuscular clinic, I've trained many of them, are pretty good at this. They're really good. They know the disease. They often send them to specialized rehab centers. So we start in a very rich environment. Furthermore, we're doing clinical research. But I understand that this is not the case across Canada and the States or in other countries. So yes, I think I would encourage everyone to be followed by people with experience, but that's sometimes hard to find. But I think the OPMD Association MDA can help you with that. So I thought today I would go item by item discussing things, and certainly in the chat, if you say there's something unclear or something you want me to talk about more, I will. So it's a list, and I'll add a little bit of material around it. So one of the things that comes out a lot in the disease is people talk about secretion, at night, the very thick secretions, and what can I do with that? That's something. And why I start with that, there are some simple solutions. The secretions they're usually not coming from your lungs. It's just because the emptying of the throat is not as good, and therefore the fungal population in your mouth grows, and it creates that very thick saliva, which is hard to remove, particularly at night, where it tends to pool even more, and then there's even more fungus that we produce. So mouthwash, very good mouthwash, can make a huge difference if you take it at bedtime in particular, and in the morning. There are people who have tried all types of other ways to decrease saliva production. I must say I have not tried it a lot, and I've had no great success, but I know my friends at the clinic in Saguenay use it more than I do, and there's all types of things, drops, using antidepressant that have a side effect of drying the mouth. I must say I have not had much success with it, but it doesn't mean it should not be explored. So it's something that you can discuss with your doctor, your neurologist, or your ENT specialist, or the people who are following you for your swallowing difficulty. Very, very important point. Statin, which are the common Crestor, Lipitor, the common drugs used for high cholesterol are myotoxic for all humans, can be myotoxic for all humans, but our OPMD patients are particularly sensitive to it. So please, if you're gonna be offered to take a CK, or if you're being offered to take this type of medication, and you have some hesitation, there are other options. And the other thing is you can certainly ask your doctor to monitor CK, which is creatinine kinase, which is an enzyme that's liberated from your muscle if they're a little bit ripped or damaged, or have some toxicity of the medication. So play safe, ask questions, but it's not absolutely contraindicated, but almost. For example, in our big cardiac prevention clinic in Montreal, and it's cardiology, if you have OPMD, they will never give you this drug, these type of drugs. They will give you others, and they will work on your diet, but they will never give you these drugs because we've learned from experience, it's so common in Quebec that some people really even lose walking on those. So be cautious. It's not absolute, but be cautious. I wanted to talk about pain management for two more important things. OPMD is largely a painless disease. Okay, so you should not expect to have pain with this disease. You're allowed to have pain, and humans are allowed to have pain, but with OPMD, there are unfortunately a few percentage, I don't know, I don't have a clear number, less than 10% of patients. Some of them are some of the most severe, which have pain syndromes, and they should be seen as a myalgic syndrome in many ways if nothing else is found. And they can be treated as such with drugs we give for people who have myalgia or severe pain. But it's not, most people don't have pain. So if you have OPMD and you develop pain, you should not explain your pain by your OPMD, but it doesn't mean it cannot be the case, okay? Physiotherapy, questions that I have every time I meet a patient, and I meet 5 OPMD patients a week and probably 2 or 3 new cases a week. So it's always the same question. Doctor, give me a physiotherapy program. There are no OPMD specific physiotherapy, but the good news is the group in Saguenay, northern Quebec, has a physiotherapist, and they're really working on developing a program. So I suspect we will have a program that will be more specific. In the meantime, physiotherapy can help you. You are trainable with this disease, so you can become stronger. And so it's worth really exploring that issue, but we don't yet have a specific program. And we've been hoping and worked, we have many trials of that, but we don't have it. But hopefully with very scientifically minded people like Elise and other physiotherapists in Netherlands and so forth, we'll be able to develop a program that will help you to stay as fit as you can. But it's on the way, guys, so it should happen. The use of cane, walking stick. I prefer walking sticks. They're less visible. They're better on ice. I'm from northern hemisphere. The cane is not bad, and as you see on the lower part of the slide, we have also a cane with a half walk or a half stair. So that allows people to go wherever they want, and then they pull down the stair, the half stair, and they can go upstairs because the height is not as high, so it's easier to bring the leg. And so that's something that we use sometimes in patients. So, but canes are useful even as a visual reminder for other people that your gait is maybe a little bit more fragile or more difficult. As I said, wheelchair and scooters are great. You can use them even if you're not very affected, but they're late, and do not refrain from using them to go from one place to the other. But a lot of our patients are shy. I tend to encourage using them if you want to go to one place or another, and then you walk. And so a lot of people will not have a wheelchair during their lifetime or minimally use it. Head elevation at night, very important for the people who have thick secretions. It really helps to have and that's why we often recommend electric beds, because they allow you to be in a more comfortable position and use gravity to empty your mouth at night. Lift chairs are very useful later on when people have difficulty leaving to start their walk. So that's usually there's some techniques to not fall, but it's really a good help on every day. There's home adaptation, again, mostly related to the ability to go from sitting to standing, which is because those are the muscles that are really affected in disease. So things can be done, and obviously access to home and so forth can be looked at. So we do a lot of that in our rehab clinic to try to help people to stay at home. Parmic permit, I give them very early. I don't want my people to fall. So even though they can still walk the distance, I prefer that they walk the distance inside in winter in particular than risking it on the icy parking lot. So I tend to give a lot of those, and it's fine, and people can decide to use them or not use them. It is their choice. Some of my patients who are really weak have had adaptive driving, but I must say it's less than 1% by far that have had to modify their car to drive. But some have gone through that, and it works well. It can be done. So if we talk about the eyelid ptosis, and that's where my caution of the beginning stands, is I'm a neurologist. I've seen 400 or 500 people before and post surgery in 30 years, and I've worked mostly with one extremely good surgeon called François Codas. So I have a very biased view of it, and I'm not a surgeon. But what we know is that there are indications to be operated. So we've learned that if you really have the eyelid covers half of your pupil, the black center of your eyes, that means that you're going to start doing some adaptation, including tilting your head backwards, and then you're going to develop neck pain. And that's very important. If you're looking in front of a screen, you may develop all types of positional pain and so forth. So past 50, please go and be assessed for surgery. At that level of eyelid closure, you also get night vision problems, particularly when you're driving. So it's really time to go. And I know people sometimes prefer to say, I'm not going to be operated. I'm one who's not, but it's really worthwhile, particularly if you find the right surgeon. There are essentially two surgeries. I must say in Quebec now, we tend to do 90% the definitive surgery, which is called suspension. So essentially with a piece of, it's not wire, it's a special fil, only the French name comes to mind, and it's sewed in the fascia of the frontalis muscle. And that the good thing about that is that it can be adjusted if it was overcorrected. That means you can't close your eyelid after the surgery, then they can come and undo the knot and bring them down a little bit. The good thing of doing it first is that when they do that, they don't go through scar tissue. Thread, yeah. They don't go through scar tissue. So the result on the eye is much better. There's less dryness because as you know, the eyelid is like a wiper. It has to really follow the curve. But if there are knots or scar tissue, it may kink a little bit. And so you have parts of the eye that will be a little bit drier, and then you get all the red eye, painful eye syndrome that you get. So we tend to do that. I never decide. It's the patient that decides with a surgeon. The other surgery has only a 3-year or a little bit more at the most, and then you have to operate again. So, and it's all under local anesthesia. So we tend to do that, and you see the results on these pictures are really, really aesthetic. And some people are concerned that, oh, well, they're going to tie, and you see that's where the knots are. They're going to tie it there, and my forehead is going to be so wrinkled because, in fact, you are using your forehead to lift the eyelids. But in fact, as you see, the forehead was far more wrinkled than before because the effort was so great to try to raise them, but now it's much easier. All right, treatment of dysphagia. So again, I'm not a speech therapist. I'm not a GI or ENT. So what I say is my experience, and you talk to your therapist and see how they feel about some of those comments. There are guidelines in France for the treatment, and we're working on guidelines in Canada. So there's still some flux as what is the good practice. But today I'm telling you my experience and what I would say if I probably saw you in the clinic. So nutritional recommendation. There's no, again, definitive diet for people with OPMD. Again, we encourage people not to shy completely away of animal proteins because it's good to keep their muscle strength. But I had a vegetarian patient who kept really good musculature with OPMD. So it's just a question of eating well, ideally not to be overweight, too much, because that is hard when you lift yourself from the sitting position later on. And you've learned from your family, and if you don't have a family you're taught it, there's a lot of adaptation. For example, keeping water at the table to push food down, eating more in sauce, cutting food in a peculiar way. When you go to the restaurant, you take food that doesn't stress you. You can eat with pleasure. And if really you have a big outing and you're stressed about it and you have to talk, a lot of people will eat before or after, just so that they won't play the game of choking at the time where they need to talk in public. So those are adaptations that most people in families have learned from their parents or their grandparents. But I suppose some of you have not had that chance because the parent didn't live long enough, or for whatever reason have had little contact with them. So when do we start thinking of surgery or other procedure for dysphagia? When it's moderate to severe. There's no criteria for moderate to severe. So if you think it's becoming too difficult in your life, it means you need to consult, okay? The dilatation is one mean, which is not a surgical, which is getting down. You can either have a balloon or a special rod to do that. Unfortunately, it only lasts for a few months to a year or two. It can be repeated up to 15 times. So you can go and it helps, but it's temporary. It's a stretching of the cricopharyngeal muscle. The surgery, the cricopharyngeal myotomy, it seems like a simple surgery, but it's not a simple surgery, and the results are mixed. I had the advantage of working with the best surgeon, I think, or certainly the most experienced, and we had very good results. But now it's fading a little bit as a surgical approach, but I'm not saying it's a bad approach. In fact, it's a good approach. But it also has an expectancy. At one point, there will be so little muscles to push the food and open the sphincter that it would still catch up with people. Now we're starting to do laser surgery, which means doesn't mean that we open. It's a laser that goes in and cut the muscle from the inside. First results are very good. I don't want to promote it. I'm just saying that's a new approach that's starting to be used in OPMD. We still have to learn more about that. Buttocks has been promoted by some. I have absolutely no experience with buttocks. It makes not much sense to me to put a drug that will need to be re-injected every 3 months. Some do it transcutaneously, some do it from the inside. It's certainly, it wouldn't be my first choice as a recommendation, but maybe some physician you will meet have a lot of experience. That's what I would recommend. In Denmark, they do it with EMG to be sure to be in the muscle, to decrease the chances of complication. Even then, it's only about 70% that have benefit. So it's not a universal treatment. So it's promoted, but I mean, you can try it. It's reversible because at one point the drug will lose its effect, but it's certainly not I wouldn't be my first choice. That's it. The other thing is very controversial. Okay, so but a lot of people, and I see that in the States and even in Canada and elsewhere, if people start choking or have an aspiration pneumonia, there is a tendency for some teams to recommend percutaneous feeding to diminish the chance of aspiration pneumonia. I hope you remember the positive news. People have a normal life expectancy. Those people don't have percutaneous feeding. It's only 1% or something like that in Quebec who will have it. I'm not saying it's not a good option, but it's really not for everyone. Many people will choke, many people will have aspiration pneumonia, but they can still feed themselves for most of their life, or all of their life, in fact, without having to go through this very dramatic decreased quality of life into it. So I'm not saying it's not a good option, but if you have doubts that it's the right time for you or your parent, please ask more questions. And many of our speech therapists are very concerned, for good reason, that you may have an aspiration and die. 30 years of practice, I've seen it once. Doesn't happen. People have learned to adapt so much that they never take a big piece of food that will cause an obstruction, for example. And they know how to play with the texture to get it down. So it's not as big a problem. So that's where if you hit a therapeutic team that has less experience, they may jump on this alternative very quickly. I would be cautious. We have patients who have both, eat and have the tube, and that's possible. So just a word of caution, not saying it's a bad avenue, it's just something that you need to be quite clear if you want it or not, and sometimes a second opinion can help you there. Sadly, still no treatment for the movement, the mobility issues that appear late in life. So clearly for the younger patients who are very athletic and having the first difficulty, do enjoy it. There's no counterindication for activity, so go for it. Enjoy it fully, but it may catch up and have an impact, a negative impact for your performance. Hopefully some of the new therapies may have a big role in improving that and changing the course. So if we turn to research and future treatment in particular, this is a long list of avenues that have been looked at or played with. I think at this point, the first thing that is in the press very much, and again, you remember my second slide, I was a medical advisor. I was on the medical board of Benetech, and in fact wanted to do the trial in Quebec, but it's all happening in New York, and the recruitment is finished, and it's happening, and I think the company is happy about the progress, is this antisense silence and replace therapy with injection in the throat through a surgery. So I can't tell you results, I don't know them, but the recruitment is completed. That's the impression I get from the company. So we should know. And this would be wonderful because this means maybe it's a potential cure therapy. So because this is reverse, it could correct the error in the muscles that are there. So let's be I'm very hopeful. Let's see how it goes. It's done very, very diligently by this company. All the other things have been discussed, tried in model, not much success. So there's no, to my reading of the literature, there's no drug coming in the next 2 years, but there may be, I just don't know about them. And don't forget, there's always privacy. Trehalose was, I thought, very good, but we don't know when Sealose will launch another trial or will launch another trial. Guanabens has been shown in many models, and there's maybe, there was a recent paper again showing that maybe a variant of this drug could be used, so not impossible. For a while, some of you may have followed the idea of taking growing muscle cells and re-injecting them in the throat or elsewhere. That has been stopped because of production issues. It's very hard from OPMD muscle to produce enough myoblasts to re-inject and have the quality needed. So that has essentially stopped. So it's one of those diseases where we have fantastic treatment for the eyes, pretty good treatment for the throat. It's not perfect. And in fact, that's why the companies are working mostly on that, because the impact on quality of life, time in hospital, and so forth is so important. And we hope that one day we'll have a drug or a modification of this approach. You can imagine that we could, in theory, inject certain muscles that are going through a hard time with a virus that would correct the dysfunction, and then the muscle could recover. That's being discussed. I don't know, because I don't do this in my lab, so I don't know if how close or how far it is, but let's stay hopeful that it will happen. Then there's a lot of patient-centered study. So there are natural studies. There's one in Canada of over 100 patients, and there's one in the Netherlands of about 40, and there's maybe others that I don't know about. There's a outcome measure. There's a lot of research in Canada where we have, as I'll mention in a minute, a very strong leadership to develop that. Netherlands have done amazing work. Denmark, France is doing things to try to get a better grasp of what are we going to follow if we're going to bring in a new therapy to see that people improve. There's research on patient-reported outcome. We want what the patient, from the patient, what would make a difference in their life. How would they say, this really changed my swallowing, my eye, my walking, and so forth. There's a lot of research, and I know the OPMD Association, it wants to be a big player in that, and already Facebook has helped, the OPMD Facebook has helped us quite a bit in our SACME venture to try to look at new tools to look at the dysphagia, for example. There's patient registry that are being discussed. We're trying to develop one through the leadership of Cynthia Gagnon and the CNDR in Alberta to try to build more of a registry with information in it to look at our large patient clientele, but there's others that I'm sure will be developed. I don't know them all. So I'm coming to the end, to the question period in a minute, but I need to thank, first of all, the MDA for their really kind, and I think it's wonderful that on Rare Disease Day, we're talking about OPMD, having worked on this disease for more than 30 years now, and it's often one of the, not forgotten, but not one of the dystrophies that we talk the most about. So I'm really delighted. Thank you so much. Thank you for the OPMD Association, Michelle and the others, Rebecca, to really become a face for OPMD patient-driven promotion of research information. Amazing. In Canada, muscular dystrophy has always been a very, very good, Canada has always been a good partner. Thanks for our granting agency, the institution where I see patients. But I want to thank I'm a Saguenay boy from Northern Quebec, but I practice there twice a year for about 20 years. But really, they're building an amazing team with Cynthia Gagnon, who was an OT, but a really international caliber outcome measure specialist in dystrophies, and a young neurologist, Jean-Denis Brisson, who's done an amazing master thesis. The data I presented is from his work, and he's becoming a tremendous clinical expert and really concentrating on bringing trials to the OP clientele. And Claudia Côté, who's a wonderful PhD student, who's now a postdoc, who's a nutritionist and very interested in developing guidelines about nutrition, and also ways to better assess the impact of our intervention on swallowing. So on this, thank you very much, and I'll be delighted to answer your questions.
Thank you so much, Dr. Bryce. I'll go ahead and start sharing my screen. And then I do want to give OPMD Association a chance to introduce themselves and talk about their association after our Q&A session. So we'll give them some time at the end of our question and answer session. So we will now open the webinar to questions for our audience. Let's see. Back to my screen for you guys. There you go. I apologize for that. All right. So we have some questions that came in on the registration. So I wanted to share those questions as well as questions that we have from the chat. So we're going to start first with a couple of questions from our registration. So the first one I have is, does OPMD ever involve gastrointestinal problems like chronic diarrhea? Gastro issues are generally not mentioned in literature.
So it's a case by case, usually not. Again, there's some people who have syndromes that look like OPMD that may have gastrointestinal issues. So be sure that your diagnosis is firm, but if it's genetically proven, it's usually not a major problem. Granted, if you modify your diet, you may have impact on your transit and all of that. I have not seen, for example, incontinence as a recurrent problem in OPMD. We see a lot of GI problem in other dystrophies, but I can't say it's a major issue.
Thank you so much, Dr. Bryce. And another question that we had was around the Botox question, which you kind of covered already, but they wanted to know, is that ever used for ptosis?
Oh, it would not be used for ptosis. So maybe just to give you, so that you understand all the therapies that we do for throat. The throat is a pulsatile sieve, not sieve, but funnel. So when this is your mouth, at the end, there's a sphincter, okay? And when you swallow, you push and you open. But your muscles are becoming weaker in OPMD, and it's more difficult to open. So all the therapies are to either paralyze the buttocks, semi-paralyze, or cut the sphincter to make it incompetent. So it will decrease the resistance. So that's the logic of the buttocks. For the eyelids, it's really muscles that pull the eyelids. So in fact, they're working like dogs. And then if you put buttocks, they're going to be paralyzed or partially paralyzed. So it's going to be even harder to do that. And the other muscle around the eye play a minor role in the eye opening. So it's really one single muscle that has to do with the help of the frontalis. So there's no logic to do buttocks. And in fact, some of my patients ask me, should I get buttocks for aesthetic reasons around the eye? And I'm always concerned. Granted, the muscle that pulls the eyelid is really deep in the orbit. So it's it's almost impossible to think that if you injected things for wrinkles that they would go in, but you, so I'm always concerned, but certainly the frontalis, the people who want, oh, I have too much wrinkling and then I want buttocks in there, that's a bad idea in OPMD because you're using that muscle to pull your eyelids up.
Thank you for that. All right, another question that we have is, would treatments for, say, ALS be promising for OPMD?
Good question. I mean, as you know, Trailose was tried for ALS also, and maybe that's where it comes from. ALS is a primary neurological disease. Okay, so OPMD, the nerve part of OPMD is in fact poorly charted. So I don't think it's necessarily the same. I don't know. So the idea is, oh, there's a new ALS drug. Should I use it for OPMD? I would never jump that. But it doesn't mean it's not possible. And we certainly, when we look at a new drug category, we may say, oh, this works on aging or something. Maybe it could be, and then it can be tried in muscle and can be tried in model. So I'm not saying no, but it's not so straightforward because it's not the same machinery, if you want, that's effective.
Thank you so much, Dr. Bryce. All right, so some questions from the chat. Someone had asked if you could explain dominant and recessive. That was kind of earlier on in your presentation, but someone just kind of wanted a little bit of quick clarification on that.
I don't know if you see a lot of me or you just see a little box with me. What do they see? Do they just see me as a small person talking?
They do, but I can make you larger if that would be helpful.
Just because I use my fingers to explain that.
Okay.
So if I don't,
let me stop sharing my screen so they can see you.
I'm not trying to impose my face on anyone. Don't. So the idea, we get a gene. Our parents have two genes, so they have two copies of the PAPN1 gene. Okay, our affected parents has an error. Okay, so when we are born, we get one copy from the mom and one copy from the dad. The dad can give the normal copy or the affected copy. So we call that dominant. That means if you do get the affected copy, then you will get the disease. So that's a dominant mode. There's many diseases that segregate that way. The recessive is the two parents have an error, difference in their gene. It doesn't cause any problem. They don't have OPMD, but then the child gets two errors and has OPMD because of two errors. But in OPMD, we call them recessive because they're very small errors. In fact, so it's really you're getting. I don't know if you remember the number 12 to 18. So they're called 11 errors. So it's just one new triplet more. And in the population, it's 1 in 2, 3, 400,000, 100 people who have them. So the two parents have a very small error. They're fine. They won't, though I think they'll never develop the disease. So there is a controversy there. Some say that they will, but I don't think they will. And then they do give to their child two copies. They don't give the gun. And then these people who get two small errors will develop a disease. So they really have a recessive disease because dominant would mean that the parents would have to have it because it crosses. You need to have it. It dominates. It's not. So, but then we get people who have a large mutation, and a small mutation, and they are compound heterozygous. So they're not really recessive, but they get two errors. They will get the disease through the big error, but the small error will make it a more aggressive or more severe disease. I hope it helps. There's beautiful YouTube things on genetic transmission. So maybe if you're still finding the concept difficult, then you can find one that will do it graphically, and I think it will become clearer.
Thank you so much for that explanation. And I know we've posted some links in the chat as well with some more information on that. We had several questions surrounding the topic of exercise. Is exercise recommended? Should patients be limiting their physical activity? What is your kind of thoughts around that?
So no good literature, so we don't know. And that's what we know from a growing field of literature is that most dystrophy people can be trained. So, and that's the philosophy at this point. Training is probably good. again, it's a question of degrees. I'm an athletic type, so I could not live without sports. So I tend to encourage my patients to be active and do more and stay healthy. And when I see really super athletes in their 50s, I say it's now or never. Just do them. Do the Himalaya now. Don't wait. But I don't say don't do it. So I think, that's maybe because there's no good data. What I like about my colleague Elise Duchesne's philosophy is that she will tell us if training really helps, and then develop programs to go to see if the muscles that are more affected will. So I think that's the kind of philosophy we have in Quebec is, let's not say you can't do it if we have no proof it's bad. And the evidence is that most people can improve their performance, and don't push it too much. Listen to your body, listen to pain, but be active.
And then
I don't think it's going to accelerate the disease.
One other kind of question that also hits the same is there one specific type of exercise you might recommend over others?
Yeah, so as I mentioned, we for the last 30 years, we've tried to get people to help us to define a program. And one of the challenges, and we haven't succeeded, these will be the first one, I hope, one of the challenges is that to train muscles that don't work all the time, training eyelid muscle, forget about it, they work all the time. Swallowing muscle, they work all the time. So tongue muscle, they work all the time. So to do more is difficult. I mean, there are exercises to get tongue muscle, and some of my patients do them, but in reality, the tongue works. And the first muscle is the muscle, the iliopsoas, the muscle to hip flexion to come up. That's a muscle that works all day to walk, to stand. So it's already a muscle that's not undertrained. So it's easier to get improved strength on muscles that are not working all the time. So that's one of the challenges is can we push those muscles to get a little bit stronger? Probably. But again, they're muscles that are already working pretty hard.
Wonderful. Thank you so much for that. And then also I had someone asking, is it normal to experience vertigo as the stability decreases due to lower limb weakness? Is that a common thing to experience?
Again, I'm a neurologist, so vertigo is a symptom that may mean many things. If I reduce it to my words, instability at walking, yes, we have people with OPMD that are unstable, particularly the ones who don't only have the hip muscle iliopsoas weakness, but have started to have weakness lower down. So even some people with severe form will have foot drops. I mean, it's rare, but it happens. Those are the most unstable ones. But most of our people keep a pretty good stability with the disease. Again, they're aging, and there's many things that can influence diabetes, nerve disease, all those things that can change. But instability is not, but it has to be really assessed properly, because that may be at a point where physiotherapists and other people will say, look, you need to protect yourself in certain circumstances. So some of those people will find themselves in wheelchairs for some mobility issues, because we just want to decrease the chances of fall. But vertigo, spinning, that type of thing is not part of OPMD in my books.
Thank you so much. We have time for one more question, even though we had so many more, but I do want to still give time to the OPMD Association to introduce themselves. So the last question, and I feel like this is a pretty important one, and we hear this across multiple neuromuscular diseases sometimes. So since there is no cure, why bother seeing a doctor?
My short answer is, if you felt that you learned something today that's useful in your daily living, that's why you see a doctor. I'm a rare disease specialist, so I have a very strong bias. So see the doctor who knows something. But again, that's my bias as a rare disease. Or to use, I always call it a men perception. If you have a Lincoln, you go and see someone who knows Lincoln cars or whatever. So it's the same thing. So I think MDA has always promoted in their clinics and their clinical activity expertise so that they can really answer your question. There's always a limit to knowledge. I know that I play a big role in sending people to the right interventions for their eyes, for their throat. I play a big role with my huge rehab team to try to get them as best as we can, find the right adjustments. I play a big role also in helping people who have to stop their work because they can't do it. So I do all the So there are many roles we can play. Again, as I said, I see patients with this disease every week. So for me, it's my everyday life. So it really finding the right service, the right person to answer your question. If that's not the case, then you have to ask for someone else. And many neurologists have seen OPMD, but they may have seen one case. They haven't seen 1,000.
That is such a great answer. Thank you so much, Dr. Brace. All right, I am going to continue to share my screen so that I can introduce Michelle Mulholland from the OPMD Association. I would like to introduce her and let her speak about their association. So welcome, Michelle.
Thank you, and apologize for the technical difficulties. I'm going to blame them on AT&T. I think we've been having issues with AT&T in the United States for a while, so thank you very much for giving us some time. I'm just going to start, and then Jessica, if you want to catch up with me in my slides, that would be awesome. So my name is Michelle Mulholland, and I'm the founder and CEO of the OPMD Association. I started this nonprofit in honor of my paternal grandmother, who passed away from complications of oculopharyngeal muscular dystrophy, and also for family members, friends, and OPMD community members whose lives are greatly affected, not only physically, but financially and emotionally, and as a result of living with OPMD, and then, of course, the people who are caring for them. Next slide, please. So I'm on to the About Us. Thank you. The OPMD Association is an all-volunteer 501c3 nonprofit established in August of 2022. We serve the OPMD community. Our primary goal is service, to provide information, support, and resources. We also strive to raise awareness of OPMD by educating the public, legislators, and healthcare organizations. And the OPMD Association creates opportunities to network and partner with other nonprofit organizations, such as the MDA, clinicians, researchers, and pharmaceutical companies. And we do this both on a national and international level. And our goal is to promote and support treatments, and as we've been discussing, maybe eventual cures for OPMD. Next slide, please. So I mentioned resources, and we have a lot of resources, but you'll find many of those on our OPMD Association website. And I believe Rebecca Hastings, my colleague, has already put that website in the chat. So for example, on our website, you'll find a list of OPMD clinicians, registries, lists of medical equipment options, tips, events, and sign up for our newsletter, which is OPMD Matters. We're expanding our list of clinicians. I mean, you talk about getting to see a clinician who actually sees OPMD patients. We're trying to expand that list. So if you have a really great doctor and you'd like to share it with the OPMD community, please put it on our Contact Us page, and we'll make sure that it gets onto the website. Also, we received many questions about testing. I saw one from Bob in the chat. And one option here in the States, the Perkin-Elmer-Lanter project provides free OPMD testing. So please check the website or contact us, and we'll give you that information. I'd also like to highlight upcoming additions to our website, especially the Caregivers Corner. We hear from people who need some help, need resources, so we're going to start that Caregivers Corner this year. Next slide, please. So as you can see, we've accomplished quite a bit in our first year. These accomplishments are due to the direct support of our volunteers, OPMD community, nonprofit and clinical partners, and also our donors. And the OPMD Association plans to continue our networking and partnership initiatives. For example, this webinar is a direct result of a meeting I had with MDA's Marissa Lozano during last year's Muscular Dystrophy Association conference. Networking is really great. It works. Other 2024 initiatives include a new podcast series, a registry project, and grant and legislative programs. Next slide, please. So the OPMD Association is planning celebrations for 2024, two of which are our nonprofit anniversary, which is August 18th. And also we celebrate the OPMD community on September 23rd during Muscular Dystrophy Awareness Month. So in closing, We are very grateful for our OPMD Association volunteers, our generous donors, and our clinical partners. Thank you for your support of the OPMD community. I want to especially thank Jessica and Marissa and the Muscular Dystrophy Association for hosting this webinar. And also the OPMD Association is very, very grateful for Dr. Bernard Brace, who is an important advocate for the OPMD community. He is an OPMD champion. So thank you, Dr. Brace, for helping us with this webinar, for conducting this webinar. And I want to open this up to all of you who are watching. You too can become an OPMD champion. Partner with us to defeat OPMD in our lifetime. Thank you.
Thank you so much, Michelle. All right, so in closing, if you are new to MDA and are diagnosed with a neuromuscular disease under MDA's umbrella, or are the loved one of someone who is diagnosed, we encourage you to stay engaged with MDA, and you can do this by visiting mda.org/join and completing a short form. It's free and it will keep you up to date on the latest resource and educational programs and supports. And we would love to hear your comments about this webinar. So at the end, there will be a screen that will pop up with a survey. If you would take a couple of moments to complete that survey, we would greatly appreciate that. If you have any questions after this webinar, please feel free to email them to mdaengage@mdausa.org, and we will follow up with you. And if you are new to MDA through this program and are diagnosed with a neuromuscular disease under MDA's umbrella, again, we would love for you to stay engaged. And you can do this again by completing that short form. This concludes today's virtual learning webinar on OPMD, and we want to thank you again, Dr. Brace, for presenting, and for the OPMD Association for partnering with us for this webinar. And we hope that you guys have a great rest of your day, and thank you so much for attending.